Welcome to Module 10, and the topic is pediatric vaccines. The topic discussed today is vaccination in immunocompromised populations, specifically focusing on HIV-infected children. My name is Rubin. I'm a pediatric infectious disease specialist at Cone Children's Medical Center of New York, part of Northwell Health, and also at the Hofstra Northwell School of Medicine. So we'll jump right into this topic on the next slide, asking the question, why is vaccination of HIV-infected children important? And there's at least three reasons why this is important. Number one, these children are at increased risk for development of infections in general, as well as vaccine-preventable infections. So, for example, pneumococcal sepsis and pneumonia is much more common in HIV-infected children than in healthy children. Furthermore, children are at increased risk for severity of infection, and a good example of this is chickenpox or varicella, which is oftentimes more severe in HIV-infected patients. Furthermore, there can be an atypical and relapsing presentation, and there can be substantial morbidity and some mortality associated with infection. And finally, there's increased risk of exposure, since HIV-infected children will have more frequent association with medical environments, which brings them in contact with other individuals with acute infections, which might include influenza and varicella. When we think about vaccination of HIV-infected children, there's also issues related to safety, and generally there's relatively limited data on safety. Certainly, if we compare inactivated or component vaccines with live vaccines are of the most concern. Remember that in any live vaccine, it's attenuated. However, the attenuation is relative, such that it's attenuated and should be safe for an individual with a normal immune system, but could be problematic and cause disease in a patient with an immune deficiency disorder. So an example of a live vaccine that we'll speak in more detail in subsequent slides, but it would be live rotavirus vaccine, which is normally given orally starting at 1 to 2 months of age. The recommendation is that this may be given, particularly because the age in which this is given is often prior to when a HIV diagnosis is confirmed or potentially even suspected. And the experience suggests that oral rotavirus vaccine is safe in HIV-infected infants. However, it's important to point out that rotavirus vaccine is not safe in all categories of patients with immune deficiency, because it's been shown to cause potentially severe and prolonged diarrhea with malnutrition consequences potentially in children with congenital immune deficiency called severe combined immunodeficiency. With all vaccines, there's a theoretical concern of increasing HIV load associated with the immune stimulation of vaccination. In fact, with some vaccines, the HIV load can be shown to transiently increase after vaccination, but this does not appear to cause any long-term harm, and so this is really not an important consideration in a decision to vaccinate an HIV-infected child. There are some challenges in the topic of vaccination of HIV-infected children, in that for the immunogenicity or protection, there's really limited data on immunogenicity and even less information on effectiveness of vaccination programs in this group. Certainly, it's well known that HIV infection may result in impaired immunogenicity and effectiveness of vaccines. And it's well established for many vaccines that a low CD4 count or a low CD4 percentage correlates with a lower vaccine response. In fact, as an example, for meningococcal conjugate vaccine, this is the quadrivalent vaccine that contains serotypes A, C, W, and Y. In a study where that was given to HIV-infected adolescents, it was clear that there was a relationship between response to vaccine, generating serum bactericidal antibody that correlates with protection, and the CD4 count. Basically, adolescents with a CD4 percentage of less than 15%, which indicates severe impairment of the T lymphocyte CD4, though that patient population essentially had no response to vaccination, even if a second dose was given. The other concept is that in an individual patient, the immune status is variable and may change over time. Clearly, we're in the era of combination antiretroviral therapy. Oftentimes, a patient can be made to have an undetectable viral load and a CD4 count that rises to the normal range. However, this can vary over time, and patients may be incompletely adherent to the regimen, so that or not respond fully to a regimen with the development of resistance, so this immune status may differ over time. Therefore, a study of a given population of HIV-infected children with a particular vaccine may not be appropriate for the particular individual patient that is being evaluated, because they may differ in their immune status. In terms of the timing of vaccination, logically the best time to vaccinate is perhaps early in the HIV infection, before the CD4 count falls. However, if the CD4 count is already low, then it's probably reasonable to delay vaccination for a short period of time if combination antiretroviral therapy will be initiated, since it's very likely that the patient will respond much better after he has an improved CD4 count and a low viral load. One example of this is in HIV-infected adults in a study in Africa. Essentially, pneumococcal polysaccharide vaccine was completely ineffective in adults with low CD4 counts. Because patients with HIV infection are immunocompromised and may have a limited response to vaccination, even when they are on combination antiretroviral therapy, it's important to attempt to minimize their exposure to vaccine-preventable infections. The most reliable intervention that we have would be vaccination of household members as well as healthcare personnel contacts. The goal is to decrease exposure to this vulnerable patient population to vaccine-preventable infections. And examples of that would be influenza vaccine and varicella vaccine. So let's discuss vaccination with live vaccines, and we'll look at a particular example of varicella vaccines. And we've already introduced the concept that a vaccine that's safe for normal persons can potentially cause disease in an immunocompromised individual. And that the varicella vaccine has been a very successful vaccine, but it's a live attenuated vaccine, and that attenuation is relative. In fact, so that we balance the potential virulence of the vaccine in this population with the need of vaccine. In the case of varicella or chickenpox, primary infection in an HIV-infected child can be severe, atypical, and cause prolonged signs, and it even can have a fatal outcome. Therefore, it's certainly the risk-benefit consideration makes it completely reasonable to study varicella vaccine in HIV children, especially those who are not highly immunocompromised. And indeed, clinical trials of varicella vaccine, the live attenuated vaccine, have been performed in HIV-infected children who are not highly immunosuppressed. And indeed, this vaccine has been shown to be safe in those individual children with HIV. And there are some effectiveness data to show that it does decrease the occurrence of wild-type varicella infections and the morbidity associated with varicella with wild-type virus in HIV-infected children. So if we summarize current thoughts and recommendations on the use of the main live attenuated vaccines in HIV-infected children, we'll take them one by one. So that MMR, the combination vaccine that has measles, mumps, and rubella, is indicated to give, and it's usually given at 12 to 15 months of age, with a second dose perhaps at 4 to 6 years of age. And it's indicated to give to HIV-infected children if they're not severely immunosuppressed, which is generally defined by a CD4 lymphocyte count of greater than 15% in children, and a second dose, like in healthy children at 4 years of age, if the patient is on combination antiretroviral therapy. As we indicated in the previous slide, varicella vaccine is also indicated with the same indications, namely if the child is not severely immunosuppressed. And in this case, a second dose is recommended 3 months after the initial dose. Both of these vaccines would be started at 12 months of age. We already covered rotavirus vaccine, that although there's limited but positive data on safety, and therefore it's reasonable to administer this to HIV-infected infants. Again, a rotavirus vaccine is a oral vaccine whose use is limited to infants under approximately 9 months of age. If we speak about non-live vaccines in HIV-infected children, there have not emerged any real issues in safety, but they are often less immunogenic. In general, the published vaccination regimens, in fact, in terms of age and number of doses for HIV-infected children, is the same as those in healthy children, with the exception that meningococcal conjugate vaccine, which is routinely given in the United States at age 11 years, is given as a 2-dose primary series rather than a single dose, with a recognition that the response, even in those children that have an adequate CD4 count, is impaired. For hepatitis B vaccine, which is a 3-dose series, it's given in the same way to HIV-infected infants. However, because the response may be impaired, there's a recommendation to routinely check for protective levels of hepatitis B surface antibody 1 to 2 months after the 3rd dose. And if that level is low, then to repeat the hepatitis B 3-dose series. Human papillomavirus vaccine, HPV, is also indicated for HIV-infected young adolescents. And some would recommend the HPV-4, which is being replaced by the 9-valent human papillomavirus vaccine, rather than the bivalent vaccine, simply because the higher valency vaccine contains types 16 and 18, which are the most prevalent types that cause genital warts, and it's well known that HPV genital warts are more severe in HIV-infected persons. Of course, the primary reason for HPV vaccine is to prevent cervical and other types of cancers. It's of interest to focus specifically on pneumococcal vaccines, because HIV-infected children are at such increased risk for that infection. And indeed, there's 2 different types of pneumococcal conjugate vaccine, pneumococcal vaccines. The pneumococcal conjugate vaccine, as well as the pneumococcal polysaccharide vaccine. The conjugate vaccines have a covalent bond of the pneumococcal polysaccharide to which the antibody is directed, and a protein carrier, and this renders those vaccines more immunogenic in young infants and in immunocompromised persons. Furthermore, the conjugate vaccine primes for a memory type or amnestic response. So certainly the principle is, regardless of the age of the child or adolescent, one wants to give the conjugate vaccine prior to the polysaccharide vaccine. So the conjugate vaccine, which is a 13-valent vaccine in the United States, is indicated in all healthy children, infants and healthy children, as well as HIV-infected infants. If a child less than age 5 years has not received the infant series, they should have a catch-up. And in contrast to healthy individuals, HIV-infected children 5 years and older who have not been previously vaccinated should receive a dose of PCV13. However, PCV, the polysaccharide, 23-valent polysaccharide vaccine should also be used in HIV-infected children. This vaccine is not reliably immunogenic in children younger than 2 years of age, so that a typical HIV-infected infant should receive the full series of conjugate vaccine, and once they turn 2 years of age, receive the 23-valent vaccine. The 23-valent vaccine gives additional serotypes not present in the 13-valent vaccine, and a single revaccination should occur 5 years after the initial vaccination with the 23-valent pneumococcal polysaccharide vaccine. There's recommended to have an 8-week interval, a minimum of an 8-week interval after a conjugate vaccine before administering the polysaccharide vaccine. And indeed, this is one of the, along with varicella vaccine, this is one of the vaccines, the conjugate vaccine, that is shown to reduce invasive pneumococcal disease and pneumonia in infants with HIV. I'll stop at that point. Thank you for your attention.